Hi, this is Nora Leibowitz from Health Management Associates, and I'm going to give a little background information related to some of the implementation work related to a universal healthcare program. And this is in preparation for our September workgroup meeting. So to start out with, let's just do a quick overview of the September meeting, including the goals, which are to understand the outcomes of the actuarial work that's being done, and to discuss and understand the work that remains in thinking about system design, so that we can think about recommended models to recommend, and also think about the next steps that are involved in work to build a coverage program. So the September meeting is going to include public comment, review of modeling results, and a discussion of implementation and administrative issues. Today's presentation is really focused on implementation in a number of areas around law and regulation. So I'm going to start out with a reminder that at the last meeting, we talked a bunch about qualitative criteria for assessing the models, and that included administration and feasibility. Both of those have implementation considerations, and recognizing that the implementation issues can be somewhat technical, we wanted to give some background on some of the areas that would need changing, including Medicare and Medicaid programs, the Affordable Care Act, the Employment Retirement Income Security Act, ERISA, and some Washington state specific issues. So thinking first about the Medicare program, Medicare is federally administered and it's federally funded. It's available to most Americans who are over age 65, as well as people under that age who have certain disabilities or end-stage renal disease. The program is split into Part A, which is hospital coverage, Part B, provider coverage, and Part D for prescription drugs. It's important to note that a Washington state change that impacted Medicare would need to maintain the same level or increase the level of benefits available to Medicare recipients now. Just as a Washington note, about 2/3 of Washington residents with Medicare are in the fee-for-service program, 1/3 are in the Medicare Advantage plans. Both would potentially be impacted by a universal coverage program. The Centers for Medicare and Medicaid Services, CMS, which administers the Medicare program, has really resisted changes to the Medicare program, and states have really not been allowed to make changes to the eligibility criteria or the benefits that are covered. However, there have been some changes related to what providers are paid. So Maryland has authority to set payments for Medicare covered services as part of its all-payer hospital program that's been going on for a number of years. And Vermont more recently enacted an all-payer accountable care organization model. Medicare has participated in ACO models previously, and the one in Vermont is really focused on how healthcare is paid for in order to curb growth and while maintaining quality and improving health. A note on getting approval of a rate-related change to Medicare can take a couple of years or more, and additional changes could be even more timely and contentious. So in the Medicaid program, which in Washington is Apple Health, although the program is jointly administered by the states and federal government, the federal law and regulations do set rules for all of the programs, in particular around the fact that Medicaid has to cover comprehensive medically appropriate services, and that includes services and goods that are not usually part of commercial benefit packages. A couple of examples are non-emergency transportation and children's dental coverage. These requirements, including limitations on what participants can be asked to pay for services, are really strongest for the what are called mandatory eligible groups, such as children, adults with disabilities, pregnant women, and that that CMS has allowed more adjustments to these rules for populations that are that have been added in addition, such as the adult expansion programs in a lot of states under the ACA. So there is a clear path for making a waiver, making changes to Medicaid program. It's called a Section 1115 waiver or a demonstration waiver. And these can and have been used to make changes to eligibility, benefit packages, and to test delivery system models. It's called a demonstration waiver because the idea is that the state is demonstrating that some alternative to the regular rules can be beneficial. And a couple of key elements of an 1115 waiver are that the state has to show that Medicaid beneficiaries would keep at least the same level of benefits that they had previously, and also show that the federal budget would not be adversely impacted, so they can't be asked to pay any more than they were without the waiver. And I think it's important to note that that waivers can impact how coverage is organized, making changes to the program. You know, states originally had fee-for-service programs, and then a lot of them have moved to using managed care organizations. That was done under waivers often. A state like Arkansas enrolls some of its Medicaid recipients into commercial plans, again under waiver authority. The current waiver for Washington is the Medicaid Transformation Project, which utilizes Accountable Communities of Health, which are regional organizations, to improve care at the regional level. The timeline for Medicaid waiver is generally 12 to 24 months, and that really depends on the proposal, which is to say that if a state is doing something that another state has been approved for, it moves fairly quickly. Otherwise, it can take longer while CMS reviews a new proposal. It also is impacted by the administration and what its goals are, the federal administration, and then the timing. So there are, particularly around federal elections, things can slow down at CMS. So moving on from the particular programs to other laws that impact how healthcare is governed. The Affordable Care Act, has wide impact, including around insurance coverage, cost sharing, premiums, and consumer protections. And this includes in Washington's exchange, which is called a Health Plan Finder. So like in Medicaid, changes can be made under what's called a Section 1332 waiver, now often referred to as a state innovation waiver. And some of the things that can be used, can be authorized under such a waiver is making changes to the way markets are structured, making changes to covered benefits, how tax credits are used, as well as the amount of premium that has to be spent on medical care, and what are called rate bands, or the amount that premiums can vary by age. Right now, the oldest participant in the exchange, for example, can't be charged more than 3 times what the youngest is. And then again, any changes have to be budget neutral to the federal government. So you can't be asking the feds to pitch in more than they would without a waiver. The timeline is 12 to 24 months, sometimes more. With these Section 1332 waivers, we have seen states that have not gotten action pull back their waivers when they feel like they're not going to get a response from the federal government. And again, there have been 10 states that have used 1332 to implement reinsurance. That started with Alaska, and then 9 other states have followed. And after the first one, it became kind of a more routine process that moved pretty quickly. The only other state that has gotten a 1332 waiver for a non-reinsurance program is Hawaii, and that was to get a waiver of the SHOP program requirements, given that the state already has a more protective, consumer protective employer mandate. Georgia is currently seeking a waiver that will include reinsurance, but also will make a significant change to the way that people buy health insurance in the state. So it'll be interesting to see what the federal response to that is and how long that takes. Another really significant law that impacts particularly employer health insurance is ERISA, the Employee Retirement Income Security Act. And ERISA regulates the administration of private sector employer-sponsored health and other benefits. It allows employers that operate in multiple states to offer one benefit package across all their workers. It also is intended to protect employee benefits and really to encourage employers to offer benefits to their employees. It's important to note that ERISA preempts states' ability to establish laws, meaning that states may not establish laws that apply to self-insured employer coverage because of ERISA. So that means the state can't tell a self-insured employer that they must buy coverage or what they have to cover with that insurance or with that coverage, which has really limited state-based health reform efforts. The impact of ERISA comes up in discussions whenever states are doing their planning. It is important to note that states may regulate insurance. The feds have recognized this is a state responsibility. However, self-insured plans are not usually considered insurance in that the employer is taking on the risk themselves and not utilizing a third party, an insurance company, to deal with the risk. So a little bit more about ERISA. Hawaii is the only state with an ERISA exemption, and this is again related to its having an employer mandate for coverage that was in place before ERISA. And other state exemptions or waivers are quite unlikely, just given how strong the law is. The law itself can be somewhat vague, and so court challenges have really been used to define the parameters of the law. A case in Maryland, for example, that would require any employer with more than 10,000 employees to pay for insurance for their employees, that was deemed not allowed because that was telling the employer that they had to spend that they had to do something in particular with insurance. However, requiring an employer to make a contribution for their employees, either through buying insurance or through paying into a fund, was deemed allowed, and that's the case in San Francisco. There haven't been any ERISA cases yet about a state implementing universal health care system that includes tax financing. It's likely that the argument that challengers would make is that requiring the state, requiring everyone to purchase or buy, get into comprehensive health benefit would force an employer to discontinue its own health coverage and support individuals' purchase of this package. But it's also potential argument in favor of this is that that both taxing and healthcare financing are areas of state authority, and so it's unknown whether a court would side with the state that was seeking to make these changes or with employers that were challenging the authority. The timeline is really unknown. It really depends whether such a program was challenged in court, and then the process of that. In Washington State, we wanted to think about some of the laws that are impacted at the state level, and obviously, for recipients of coverage that are impacted by these other areas that we've talked about, that is an impact. Those are all impacts in Washington. But in addition, currently the health insurance market is in the individual market, small group, large group, and association and trust coverage. Again, noting self-insurance is not generally considered insurance for the purpose of state regulation. It's worth noting that individual and small group plans are generally, those plans have more oversight at the state level, more regulation than is on large group and association plans, and obviously self-insured. In order to make a few changes, there would obviously need to be state legal action, laws around adding state subsidies to improve health plan affordability, which could be part of the option C, merging markets, the individual and group markets, and requiring participation in a universal program under A or B options, or offering cascade care to undocumented individuals could also require the development of a program that would be legislatively approved. It's worth noting from a timeline perspective that doing this kind of work could take 2 or more legislative sessions, plus the time to submit waivers and go through negotiations at the federal level. So just as a recap, thinking about the programs, noting that Medicare getting a waiver approved is likely to be quite an intense challenge. It's a clearer pathway for Medicaid and for the ACA, with the time taking, depending on administrative considerations, including who's running the federal government and what the timing is relative to election seasons. For ERISA, again, there's a potential legal challenge. We don't know how that would pan out. And then for Washington State challenges, the legislature would need to approve significant structural changes, which obviously is dependent on who the legislators are and what the state administration looks like, and that will take time. And so just keeping in mind that this is a process that is going to be at least 5 years, probably more, for health reform law to pass in the state, waivers to be developed and negotiated, and to go through a potential court process around ERISA. So we look forward to talking with you about administration, including these implementation issues, but of course also all the other things that go into running a health program. So look forward to talking to you very soon.